Well, good afternoon, and it's a privilege to be here today. The American healthcare system is rapidly walking towards a cliff. And if something is not done to transform it, to innovate, to apply technology, it will step off that cliff and drop to the ground far below. The American healthcare system is most similar to a 18th century cottage industry. It's fragmented, doctors scattered across communities, hospitals, single hospitals in every town. It's paid on a piecemeal basis. It's called fee-for-service. It uses technology from the last century, not the current century. And it has no effective leadership, particularly at the delivery system level. Those are not my opinions. Those are simply the facts. American healthcare today consumes 18% of the gross domestic product of the largest, most wealthiest nation in the world. That's over $3 trillion annually. Put that in perspective. We spend more on healthcare in the United States than every nation across the globe, except for Germany, Japan, and China, spend the totality of goods and services produced and consumed. We spend more on healthcare in the United States with about 300 million people, than the nation of India with 1.2 billion people spend on everything its citizens consume or produce: food, clothes, housing, transportation, education, and healthcare. We spend more on healthcare in the United States than the nation of France spends on everything, including champagne and truffles. Yeah, we spend a lot on healthcare in the United States. And at the federal level, it's even worse. The federal government today spends 40% of its tax revenue on healthcare. And at the rate that healthcare is going up, and the demographic reality of 10,000 baby boomers joining Medicare every day, it will spend 60, 70, 80% of its tax revenue on healthcare. It can't do that. The Constitution of the United States says it has to raise an army. It has to do infrastructure. It has to pay Social Security. And by the way, we owe China $1.2 trillion that has to repay. It has to do those functions. It can't do that if healthcare costs keep going up. And at the commercial level, it's even more of a problem. Businesses can't afford the cost, so they're transposing them on to employees. 2010, 25% of employees had a high deductible plan. By the way, when you have a high deductible plan, 80% of the time, all of your healthcare costs are paid by you out of pocket. The insurance pays nothing. Today, it's not 25%, it's 40% and going up. And the quality we get, it lags the other 20 industrialized nations. We're in the lower half of every measure, last in life expectancy, childhood mortality. You may have read last week, a girl born in Seoul, Korea today has a life expectancy of 90 years. In the United States, it's 7 years fewer. As the MC was kind enough to do, I have a book that I'm writing. And the book is called Mistreated: Why we believe we're getting good health care and why we're probably wrong. I wrote the book because I'm a big believer that we have to change American health care. Change the way it is fundamentally structured and paid and technologically supported. I believe strongly enough that any profits will be donated to a charity, actually, to provide care to people in the United States and across the globe. But I also wrote the book for very personal reasons. I begin with the story of my father. My father died on the East Coast from a medical error. A medical error that would have been avoided had there been a comprehensive electronic health record. An error that every physician knew what he needed, but they all assumed that someone else had done it. In the end, he didn't get it done, and he ended up getting septicemia and dying. In the book, I trace many of the problems of the American healthcare system, focusing on a lot of the legacy players, the problems in the pharma area, large medical societies, the structure, talk about the ACA and how it expanded coverage but did little to change how care is delivered, and focus on the new rancorous debate in Washington, D.C. And once again, it's focused on coverage and how much we'll pay, not transformation, not change in how health care is provided. In the book, I focus on technology, and given this is a technology conference, I'm going to focus on that very narrow segment of the book, or pieces of it. And I talk about our obsession as a nation with that which glitters. And some of the things have tremendous value. In fact, I believe that we're only harnessing 10% of what's possible with what we already have in the technological sphere. And yet other things turn out to be fool's gold. So I thought it'd be interesting today for me to offer my thoughts on 3 technologies that I believe have yet to fulfill the hype, and 4 that I believe are underutilized and I think have tremendous potential going forward. And I want to be clear, when I talk about companies or companies that have the hype more than the value, I'm not talking about Theranos, a total scam that created by the media and by the investors that didn't have a product to support it. We're talking about very powerful tools. One good example to me is Watson. Watson is a very powerful computer system. It's what a jeopardy. Watson can answer questions in nanoseconds that take other computers milliseconds and seconds. Watson can peruse 2,500 medical journals very, very quickly. The problem is that those are not skills that make much difference in medicine. And that's the difficulty with Watson. We don't make decisions in nanoseconds. Maybe traders on Wall Street have to worry about that. We make them in minutes, hours, days sometimes. And it's not a question that American doctors don't know, can't get the information from 2,500 journals. It's all put together. You go to UpToDate, you can find the right solution. It's that we don't do the right thing on a continual basis. And when we talk a lot about artificial intelligence, very little of the technology today that's called artificial intelligence is artificial intelligence. It's just sophisticated computers with algorithms. And so far, I think the hype in that area has exceeded the value. It may not over time, and certainly some of the natural language processing has been important, but overall, the value, I think, has been far less, and it's been a technology in search of an application. The second one that I'll talk about are the wearable exercise monitors. How many of you have one on your arm now? Yeah. So the wearable exercise monitors do 2 things, right? They tell you how far you've gone and whether you slept last night. In terms of how far you've gone, your iPhone's sitting in your pocket, wherever mine's sitting, wherever your iPhone's in your pocket tells you the exact same thing. In fact, a $5 plastic pedometer tells it to you just fine. And in terms of whether you slept last night, first of all, you know. But if you don't know, it doesn't do any good to help you sleep. So the application of that, and why I talk about that, is a very important principle I'll come back to when I talk about why it's so difficult to monetize technology, which is, what's the problem it's trying to solve? The idea that the Fitbit is trying to solve the problem of American healthcare is just wrong. In fact, the data actually says that if you enter into an exercise program with a monitor or an exercise program without one, you do better without one, or a diet program without one. It solves a very important problem. December dilemma. Christmas or Hanukkah's coming. There's someone you love a lot. You want to give them something they'll always wear, really cool, know how much you love them, and it costs between $150 and $200, right? So that's why you got one. It solved a major problem, but it had nothing to do with your health. By the way, in the 1990s, it was the inline skates. The inline skates, half of the people never took them out of the box after the first day, but they also solved that problem. What's more interesting, and I know many of your companies are in this area, is the issue of medical wearables. And by the way, I want to be clear, I'm not talking about something that sends 100 EKGs out continually. First of all, if you have two normal EKGs, 100 of them don't help you at all. But more importantly, what does it do? I'm going to send it to your doctor. How many doctors do you think want to get 100 of your tracings? Now be accountable for them and stick them in an electronic health record and slow everything else down. No one does. A question I pose, and I want to go back to this theme, what's the problem you're trying to solve? What I would love to do, and I ask my hospital physicians this all the time, if I could monitor every function of a patient, blood pressure, pulse, EKG, glucose, oxygen, you name it, how many people that you're going to send home tomorrow morning would you send home from the hospital tonight? Because if that worked, we would have a device that would have a lot of power. And right now, so far, the answer is almost none. Because we don't keep people in the hospital today to monitor them. We keep them in the hospital to treat them when the monitor says something's wrong. And as soon as I send you home, and I know there's a problem with your blood pressure or oxygen, you're too far away for me to intervene in the timely fashion that I need to. Now, I do believe that there is a tremendous application that someone will develop. And that is a wearable device that will tell the patient when they're in trouble and tell the patient when they're not. That would be very, very important. Why does no one yet develop it? Because first of all, it would be a very sophisticated medical device with regulatory issues. But more importantly, that it would create malpractice risk if something went wrong. That's the application that would solve the problem the doctor and the patient have. But that yet is a device that has yet to be created. So what about the things that do work? The first one I want to stress is the comprehensive electronic health record. And I want to differentiate the electronic health record that is simply a standalone computer system in a doctor's office. That's better than the illegible handwriting, but it doesn't add a lot of value. In fact, it probably slows the physician down overall. And I'm not even talking about interconnectivity of systems, because the truth is doctors don't have the time to go into someone else's record and get the information all the time. Occasionally, but not very, very often. But the type of comprehensive system we have in Kaiser Permanente today, where all of the information is readily presented to the physician every time you get care, is what makes a big difference. National Committee for Quality Assurance surveyed 1,000 programs in the United States and only one. KP in Northern California got 5 stars for both commercial and Medicare. You look at the outcome, 90% colon screening against 50%. We've watched the colon death rate dropping in Kaiser Permanente. Every place else it's rising. What we know is that hypertension is controlled 90% of the time in Kaiser Permanente, 55% the rest of the time. Because that system is there, the information is there every time you see the physician, 40% reduction in strokes. The second part that ties into the electronic health record is video. I believe video will be a game-changing technology for American medicine. Today, it's the fastest growing part of the care that we provide. It's a cheap technology. It's easy to use, easy to implement. You can do it on your phone. You can do it on your computer. We use it today. We have a neurologist who's available and sees every patient who walks through the door in an ED in Northern California who may be having a stroke. That individual now takes command immediately, not seeing the ED doctor, not getting evaluated by the nurse, not getting called 30 minutes later. What's called the door to needle time. How long between walking to the ED door before you get your clot-busting TPA has been halved from anyone else in the nation. It's under 30 minutes now. And what that accomplishes is not only saving lives, it saves brain function. The opportunity for patients, wherever they are, whenever they might be, traveling the world, at work, at home, to avoid having to miss work or school and drive into a medical center to get care. I believe that 20, 30, maybe 40% of what we do today in the physician's office could be done through video with not only excellent quality, but based upon our survey data, actually higher satisfaction than when the patient comes in. Some of you saw I walked with crutches. I had an accident where I got run into by someone and broke my knee. And when the physician who operated me, I actually never saw in person. I did a video. He had my electronic record. He had my EKG, my x-rays from another facility. And then we scheduled the surgery, and he met me on the day of surgery. That's the opportunity to make the care in healthcare as convenient as it is every place else. Third one is data analytics. And data analytics, to me, again, is not artificial intelligence or some strange looking into literature. It's taking information from our 12 million electronic records and putting it together in very, very sophisticated algorithms that allow us to predict the future. Today, we monitor every patient in our hospitals, And we're able to predict which patients tomorrow will be in the ICU. I call it doing tomorrow's work today. And why is that important? Because if tonight the patient actually suffers the complication they would have had, even though you resuscitate them, their mortality goes up by 4 times. We use the same artificial intelligence in the ED to predict which patients are going home today would be coming back tomorrow. We use it in the neonatal ICU as to which children are likely to develop sepsis. What's going to happen tomorrow? And we can take care of it today. That is what technology can allow to support the physicians. And finally, I think one of the biggest issues is physicians doing the right thing all the time. And the technology there is called Siri. Siri has an amazing memory. Siri can remind the physician every single time. Siri is easy to use. And that ability to take the information and put it into an application that Siri can now remind the doctor, as in my father's case, did you do all the right testing? Did you do all the right prevention? Did you give the vaccine that he needed so that he would not develop the sepsis that he ultimately died from? I get asked a lot, why is it the technology is so hard to implement in healthcare? And I offer 3 solutions, 3 reasons. The first reason is what I said earlier. Technology is usually invented, and then they ask, what is the application of it? And instead, you need the reverse. What is the problem you're trying to solve, and now what technology we're going to use? And most often, it's going to be a technology that already exists. Second thing about it is that people don't think about how to monetize it. Insurance company, hospital, doctor, patient, none of them want to pay. And figuring that out. But more importantly, I think, is the fact that we often need to transform the care delivery to actually use the application. And I believe that care needs to be integrated. Doctors working together both horizontally in specialties and vertically between primary care, specialty care, inpatient, outpatient care. It needs to be paid on pay-for-value, not simply piecemeal fee-for-service. It needs to be technologically supported, starting with electronic health record, but through mobile and video and other tools. And it needs to have strong leadership, including at the physician level. Very little of all that exists in most organizations outside of integrated systems like Kaiser Permanente. Let me close my comments with one last thought for the clinicians in the room. I told you that my dad didn't die when he had his medical complications, medical error. But a couple of years later, as a result of the medication changes that had to happen around the problem he had, he ended up developing a bleed into his head, into his brain. He was in Florida at the time, and my brother and I flew out there. My brother is the chairman of anesthesia at Stanford. We flew out there when we arrived, and my father was in terrible shape. I mean, he was clearly going to die. His brain was never going to work the way that it should. And there was a line of physicians wanting to come talk to us. The ENT doctor wanted to do the tracheostomy. The GI doctor wanted to put in the feeding tube. The neurosurgeon wanted to take out a piece of bone so his brain could swell. And my brother and I knew enough to say, no, thank you. It's not what my dad would want. After we had those conversations and we said we didn't want any more care, we never saw a doctor again. In American medicine, there's no way to code for compassion. There's no CPT number you can put in place to hold the patient's hand, to talk to a family. It was bad enough, all the other things that had happened, but that sense of being left alone, that sense of being abandoned at the end of the life of someone you love was really very problematic. And so my advice to you and my request to you is that healthcare has got to be high-tech, but it also has to be high-touch. And if all we do is we swap compassion for technology, I believe we will have lost in the exchange. So I encourage you, as you develop the tools and the applications, and those in the audience of clinicians apply them, that we have to make sure that we do the things that bring us to the 21st century, but never lose the compassion, the values that have held medicine together for 5 millennia. Thank you very much.